All right, on this episode, we're going to talk about non-invasive ventilation, define some of the parameters, and have a discussion about maybe some titrations we can do to help easier facilitate synchrony in the acute respiratory distress patient. All right, so the simplest version of non-invasive is CPAP. That's continuous positive airway pressure. There's multiple ways that you can apply this to a patient. You can use standard CPAP devices, which use high flow oxygen at really high flow rates to kind of generate that pressure. There's sealed mask type devices, which can create that back pressure, or you can do it in a very basic format with just a PEEP valve and a BVM. You place the BVM mask, create a seal, put the PEEP valve on. You don't have to squeeze the bag. You're just letting the patient breathe, and that back pressure is providing PEEP, providing CPAP. That's all it is. It's a one pressure. The advantages to CPAP or to PEEP in general are improvement in oxygenation. It increases the solubility of oxygen, allows it to dissolve into the blood more easily. It also is going to provide lateral pressure within the airways, which is going to help stent them open, which can improve laminar flow, and in some cases actually improve ventilation a little bit. Obviously, there's better and easier and more effective ways, but it does at least aid in that in some way. And then one thing to consider is the higher you go on your CPAP, the more pressure that you're providing. Problem is that it's continuous, so there are patients receiving that pressure whether they're breathing in or out. So as you go up, they have to breathe against it, and then when they breathe in, they're not really getting any assistance. And so if you have a ventilatory issue, i.e. you have work of breathing present, which is present in virtually all of our acute respiratory distress patients in the emergency room or in the pre-hospital environment, then CPAP is going to be kind of ineffective, which is what most of us saw. Is when we applied it to our patients, it was certainly a step up from a non-rebreather mask or trying to bag a patient, but it was highly ineffective at treating acute respiratory failure, especially when we're talking about end-stage respiratory disease like COPD, bronchitis, etc. So in any patient that has work of breathing, I would argue that BiPAP or BPAP or bilevel or true non-invasive CPAP less pressure support, there's a million names for it, which also should be illegal in my opinion, that they have so many different names for the same thing, because all it does is confuse providers. But in essence, whatever, when we're talking about BPAP, we're talking about two pressures. So you still have CPAP, you have in this case, that's what the EPAP represents. That's just the exhalation pressure. That's that constant pressure that's being provided. And then there's a second pressure with this strategy. It senses the patient take a breath in, and then it increases the pressure during inhalation, which provides an assist and removes work of breathing. This is a truly beneficial therapy in any patient with work of breathing for the most part, and certainly for your bronchospastic diseases, especially COPD. But I've had huge successes with it in virtually all cases, whether we're talking about cardiogenic or non-cardiogenic pulmonary edema, your aspiration patients, your pneumonia patients, your COPD patients, even other types of acute respiratory distress. It's very, very helpful, and it's very simple to use. The trick to it is getting the patient to sync. So unlike CPAP and some of these other, or non-rebreather mask or BVM, some of these other more basic devices we use, BiPAP is beautiful, BPAP is wonderful, but you have to get the patient to sync. And so there's some other settings that are kind of a little bit more advanced that we're going to talk about that can help improve patient synchrony. The graph that I have on here is not really necessarily that representative of the dynamic changes that are occurring when the patient's on BiPAP. I just wanted to use this as a very simplified version to start with, to just give you an example of what fundamentally is occurring, which is this oscillation between two pressures. And that change in pressure, that oscillation between your EPAP and your IPAP, is known as pressure support. And in virtually all of the ventilators and non-invasive devices that we're using in the ED or in the pre-hospital environment, the vast majority of them, the pressure support is PEEP compensated, meaning that it is additive to the EPAP. So if I have a pressure support of 10 and an EPAP of 5, it's going to go up to that pressure of 15. There are vents, just as a caveat, where pressure support isn't compensated for the PEEP, so that would mean that if you set the pressure support at 10 and an EPAP of 5, it would only go up to 10. So it's important to know that because when we're making these settings and titrations, we need to know how much we're going up by, because that's going to make a huge difference in the amount of work of breathing that we are reducing in the patient. So when I'm programming the BiPAP and I'm setting it up, these are the kind of the parameters I use. A little bit of a debate, talk to some people, and everybody's got a little bit of a difference of opinion. I have BiPAP quite a few people with great success, so I promise if you're a novice with this is the way you want to go, especially if you're working in the pre-hospital environment, especially if we're talking about that acute initial therapy, right? So my experience is going to be with initiation of BiPAP in the emergent respiratory failure patient. I'm not talking about working in the ICU or in different departments where maybe you're dealing with different stages of respiratory disease. This is initiation in the acute respiratory failure patient. And so you really have three settings to start with. It's pretty easy. You have an IPAP to set, an EPAP to set, and an FiO2. Some vents you don't set the IPAP, you actually set the pressure support, and then that calculates your IPAP, whatever, same thing. So I typically start at 15 for my top number, 5 for my bottom number, and then I typically start my FiO2 based on the patient. So if they're moderately ill, maybe I start at an FiO2 of 50%, maybe up to 70%, in the more significant cases, maybe all the way up to 100, although I'm not really sure you're making much of a difference once you go too high above 70%. Now, one thing that I'm pretty rigid on is whatever I set for my EPAP and my IPAP, I try to keep them at a difference of 10. So I always try to keep a pressure score 10 to start with. There are times where I'll start my EPAP lower, maybe even below 5. I might start at 3 or 4, especially in a patient whose hemodynamic status is questionable. The EPAP is going to have the most effect on their blood pressure. Remember, as a review, it doesn't really matter whether it's BiPAP, CPAP, BVMs. When you're a ventilator, when you're applying positive pressure to a patient, that compresses the vena cava, applies pressure to it, and that reduces venous return, which in turn reduces cardiac output and blood pressure. Especially in patients who have vasodilatory or hypovolemic type diseases, they're going to bypass positive pressure. It's going to have the most profound effect because the IVC will be the most collapsible in that disease process. Of course, it can cause hypotension in any of the patients. It's always something to screen for, but definitely in those patients like your septic patients and your dehydrated patients, we're really watching those. You can see pretty big jumps, or I'm sorry, drops in blood pressure with that. So always something to kind of pay attention to. That being said, we bag dead people who have a blood pressure of nothing, and bagging people also drops blood pressure. So again, I'm not saying we shouldn't bag dead people. I'm just saying that this is the kind of thought process you need to have. It frustrates me because I see protocols where they're like, oh, you can't BiPAP somebody because their blood pressure is low. You can't put them on ZPAP because their blood pressure is low. But then they don't have that same protocol for bagging, even though bagging is going to cause the same hypotension. So again, I don't think you should BiPAP somebody who has a low blood pressure. I think you should improve their blood pressure first. But for you, the provider, when you're doing a risk assessment, just keep that in mind that bagging a patient causes hypotension just like non-invasive. I would actually argue in most cases, non-invasive probably causes less because most people have a tendency to hyperventilate or overly ventilate their patient when using a BVM, which is going to cause even more hypotension. So for me, run-of-the-mill COPD exacerbation, I'm going to start them at 15/5, somewhere around 0.5 to 0.7 FiO2. If they're small in stature, maybe hypotensive, or maybe not hypotensive, but have like a soft blood pressure where their hemodynamic status is questionable, maybe I'll start them at 13/3 or 14/4. And then I'll kind of titrate from there. Now, one thing to remember, the difference between the pressures, the greater that difference or the greater the pressure support, the more ventilatory assist they're going to get. And then the PEEP or bottom number is going to be helping to contribute to improvement in oxygenation along with the FiO2. Yeah, and two, with your EPAP or your PEEP or your CPAP, that also helps to balance that pressure differential that can occur with like cardiogenic pulmonary edema. So if I'm trying to displace pulmonary edema, the bottom number is going to be more helpful. So I'm going to be quick in my CHF exacerbation, let's say, to maybe up titrate my EPAP from 5 to 6 to 7 to 10 to try to offset that when I see pulmonary edema. One other thing to note is I will rarely, if ever, go above 20 with my IPAP. Once you get above that, you start to worry about opening the lower esophageal sphincter and causing gastric insulation. And so we'll avoid that in most cases. Remember too, kind of a universal when you're reporting your BiPAP settings, you typically report it as an IPAP over your EPAP at your FiO2. So my standard jump off might be 15/5 at 0.7 or 70%. And that's how I would report that. That should be universally understood. So if you put BiPAP on somebody in the field or in the ED, you probably encountered a patient or several patients where you just couldn't get them to sync. And so there are some extra settings that we can adjust that can help facilitate that. Now, before I even get into this, some other things to always to consider is what type of respiratory disease pathology am I dealing with? And have I provided the right pharmacologic interventions? Have I got a good mask seal? Are my initial settings appropriate? Have I provided verbal, what I call verbal sedation or verbal de-escalation, right? Did you just sneak up behind your patient and jump out from behind the jump seat and throw the mask on them? That's of course going to make it less likely for them to comply. So, you know, basic stuff first always. But if they're failing that, and you're most likely to see some asynchrony in the tachypnic bronchospastic patient, and there's a reason for that. For one thing, BiPAP is a machine. It has to cycle through these process from EPAP to IPAP and back. It has to cycle through. That takes time. And the faster your patient's breathing, and especially in bronchospastic disease where they have a very quick inspiratory phase and more prolonged exhalation phase, you're going to want to have the machine keep up. And so there are some parameters you can adjust to help that process. And the first one, and I would argue probably the most impactful, is rise time. Rise time is the time it takes for the machine to go from the EPAP up to the IPAP. So that's how long it takes to deliver the pressure supported breath, to get it up. And so if I have my setting set at 15/5, then it's going to take a specific amount of time to get from 5 to 15. And that's a default setting. And unfortunately, especially if we're talking about pre-hospital environment where a lot of providers are using vents like Ravel or Z-vent, those rise times can be longer than what you would want in a bronchospastic patient. For the Z-vent especially, the default, I believe, is 600 milliseconds or 0.6. And so that is about 6 times longer than what you would want in a patient who has severe bronchospastic disease. We typically want it to be about 100 milliseconds or 0.1 seconds. And so if I shorten the rise time, that's going to increase decrease the time, that it takes for the machine to go from 5 to 15 or whatever you have set. And so it's going, the initiation of the breath, the ascending limb of the breath is going to become shorter or quicker. Now the overall breath duration will remain unchanged. It will just reach the peak pressure more quickly, and then it will stay at that peak pressure up to a certain point based on the patient, and that's going to be the other setting we're going to talk about. So the front end, or how quickly the breath is given, is the rise time. Now, if you have a vent in front of you, you can actually play with this, and you can feel what I'm talking about, and it'll make a lot more sense. So if you know how to go into your vent, I want you to go in, I want you to hook up the test lung, and I want you to pull on the test lung when you're in BiPAP mode on whatever default rise time you have, or maybe even if you can, turn it all the way up as high as you can. And I want you to pull really quickly. When you're pulling quickly, that's mimicking the accessory muscles and diaphragms of the respiratory patient. And so if you pull quickly, you'll notice, especially if your rise time's high, that you're pulling faster than the machine can keep up. And so you'll pull in, or you'll pull out, I'm sorry, and then the machine will give the breath top of it. And so if you think about the patient, that's what's happening when you see asynchrony of the bronchospastic patient, is they have this very quick inspiratory phase, and so they breathe in and they have to pull the air from the circuit through all of that hose, through the vent itself, and about the time that they've already finished breathing in, the machine's just kicking in, it's just catching up and it's trying to push that breath in, and they're ready to be done. And so then you get that asynchronous breathing pattern. And so if you shorten that, that's going to increase the speed that the breath is delivered, and it's going to match the patient's inspiratory breathing pattern. So there'll be less latency. Well, if rise time is on the front end, then flow termination is on the back end. So flow termination is what controls the duration of the breath. And in fact, any spontaneous breath that a patient takes, whether they're intubated or not, you really want the breath to be flow terminated or flow cycled is what it'll sometimes be called. Again, every vent's got different ways of talking about it. And so you can program when the breath ends. So what flow termination or what flow cycling means is that it gives control of the duration of the breath to the patient. If the patient isn't breathing, then those breaths are time cycled, meaning that it's just a set time. So you set, let's say your inspiratory time is set at 1 second, then the breath is given at 1 second. It doesn't matter. And so in a spontaneously breathing patient, that can be very uncomfortable because maybe I don't want to breathe for 1 second. Maybe I want to breathe for 0.6 or 0.8 or 1.2. And so to give the patient control, you transition from a time cycled breath to a flow cycled or flow terminated breath. And so rather than looking at time, it looks at the inspiratory flow rates of the patient to realize when the breath is about to be over so that it can allow for the patient to exhale. And this is a parameter that you can set. And when you adjust it, it will adjust the overall duration of the breath. So this is another thing that in a bronchospastic tachypnic patient, I can utilize to try to shorten the machine's breathing time to better match the patient. And so it's a little more obscure than rise time. Rise time is pretty straightforward. Flow term's a little bit more harder to get, but I've got a graph up here. And one caveat. Especially I think it's the Z-vent, doesn't call it flow term, they call it cycle loss percentage. It's the same thing. What it's saying is if it defaults to 25% in most vents. And so what that means, and that's what I have represented on that first breath you see there. So now we're not talking pressure anymore. So the graph's different. This graph we're looking at is flow, and you can also notice that there's a positive and negative flow. That's representative of breathing in and breathing out. So when we go into negative flow, that's the patient exhaling. Okay, so you can actually see here the patient breathing in and breathing out. So on the first breath, I want you to track that waveform. You'll notice that it peaks at 80 liters per minute. So that is the peak inspiratory flow. Now, if my flow termination is set at 25%, what the machine is going to do is it's going to read that inspiratory flow, and whatever it peaks at, whenever that flow rate drops to 25% of whatever it peaked at, so in this case 80 liters per minute, it's going to stop helping. It's going to terminate the assist, and it's going to allow the patient to exhale. So 25% of 80 is 20. So what would happen is the patient, if they had a peak flow of 80 liters per minute, when that flow rate dropped to 20 liters per minute, the machine would go, hey, this person's done breathing, and it would allow exhalation to occur. So I want you to go one waveform over, and you'll notice that that waveform is shorter. It's not as wide. And again, your x-axis here is time. And so this breath duration is shorter. What I did was I turned the flow term up. So I went from 25% to 50%. And so the peak flow stayed the same. It's about 80 liters per minute. So if you figure some quick math, 50% of 80 is 40 liters per minute. So in this case, when the inspiratory flow peaked at 80, as soon as it dropped below 40 liters per minute, it said, okay, we're done. And it allowed the patient to exhale the breath. So if your patient's breathing 40 or 50 times a minute, this is going to help the machine keep up. And imagine if you use flow term and you use rise time together, both things in tandem are going to shorten the overall breath cycle. Rise time is going to shorten the inspiratory ascending limb of the waveform, so it's going to reach the pressure more quickly, and then flow term will determine how long it stays at peak pressure. Now, in my experience, I feel like rise time is more effective or more helpful. I can't explain it to you. I'm just telling you that in my experience, that's what I've seen. There is some evidence to show that really adjustments of 25 to 50% don't make a huge difference in patient synchrony and compliance. But again, there's no harm in doing it. You're not out anything. It's easy to adjust. In patients who have CHF, pulmonary edema, who don't have restrictive lung disease, the effectiveness is going to be less. I'm not saying you wouldn't try it in that patient, but this is really going to shine in the obstructive lung disease patient. All right, guys, thanks for watching. I was trying to make this short, and we're still at 20 minutes, so I'm never going to be able to transition to TikTok for sure.